Hello everyone, this is Dr. Pruitt. Welcome to this week's EKG. This week we have an interesting case of an 84-year-old male who has a history of high blood pressure and diabetes. He's also got a history of atrial fibrillation, and he's telling you that he's dizzy. You get your first set of vital signs and you see a heart rate of 85, but on the monitor you see the range for the heart rate jumping anywhere from 70 up to 90 kind of irregularly. Blood pressure is 169 over 118, pretty high. I'd take note of that mentally. Oxygen looks good, his respiratory rate looks fine, and his sugar is normal. And so one important thing to just think about as you're taking histories for your patients that have atrial fibrillation, there's a huge stroke risk that comes along with having atrial fibrillation, and a lot of times they'll be on blood thinners. And especially for elderly folks that are feeling dizzy, it's important to ask about the blood thinners, because if they've fallen recently and hit their head, they're at increased risk for having an intracranial hemorrhage. And so when you hear AFib, instantly think, I need to ask about blood thinners. And so here's your EKG that you get. I'll give you a second to take a look and see what you think, and then we'll go through it together. We'll do this the same way we do every time. We'll start with the rate. Like I said, on your monitor, you see it kind of jumping around with different rates ranging between 70s, 80s, but on this 12 lead that you capture for this 10-second period of time, your computer's telling you it's 86. But what I see here, normally where we could just, if it's regular, we could just find a QRS that lines up with a thick red line and count down 300, 150. This rate right here is somewhere between 100 and 150. That's a lot higher than the 86 the computer is telling you about. But if you look here, you line up with this thick red line here, you do 300, 150, 100, 75. So this rate here looks like it's 75. So it really is kind of jumping all over the place. But for our purposes here, we'll say it's somewhere in the 80s. I'll give the computer credit for whatever it decided to calculate there. But when we get to the rhythm is when this is really important, because we mentioned it just doesn't look regular. And there's no, like here is pretty bradycardic between these two here, but then this one accelerates really fast, and then this one looks a little more normal. And so it's not predictable. I don't see any pattern here, like long, short, nothing is really sticking out. And so what we call this is an irregular rhythm. And so we've determined our irregularity. The next question is, where are the P waves? Do we see P waves before every QRS? And again, I'm seeing a bunch of little waves right here. Lead 2 is always a good place to look for P waves. Lead V1 is also a very good place to look. But as I'm looking here, I think I may see one there, but this one's upside down. I don't see one here. All of this kind of squiggly line that's really hard to discern. And same thing up here in V1. And so I would not call this a sinus rhythm, because there's no P waves before every QRS, and it's irregularly irregular, which is the EKG that's very consistent with atrial fibrillation. But let's go on and see what else we can discern from this EKG as we move forward. So let's look at our axis. If you remember, we look at 1 in AVF. So we're up in lead 1, left thumb is up, that's good. We're up in AVF, 2 thumbs up, we have a normal axis. Axis looks okay. Next we move to our intervals, the two that we're most concerned with, QRS and then our QTC. QRS is less than 120, that's good. QTC is less than 450. If you remember, 450 is where anything longer than 450 we call prolonged. Greater than 500 is where they're at risk for spontaneous arrhythmias. This one looks fine, so I'm happy with our intervals here. And lastly, we look at our ST segments. And I tend to do this in territorial distribution just so I don't miss anything. So starting with 2-3 AVF, these are our inferior leads. And we're looking for any ST elevation, T-wave inversion, anything that catches our eye. And one thing that does catch my eye here is we do have some T-waves that are inverted, but they're not necessarily ST depressions. I would just take note of that right now. And then we move to 1 in AVL. These are our high lateral leads, which if anything's going on in your inferior leads, you'll see reciprocal changes here. And I'm not seeing any ST elevations or depressions here, so that looks okay. We'll move to our septal areas. Again, no ST elevations, T-wave inversions, ST depressions. And then our anterior and lateral leads look good as well. So a couple flip T waves anteriorly, nothing huge, but maybe something to keep an eye on. And so what we have here is atrial fibrillation, and he told you he had a history of AFib, so that's what we see. We've confirmed that on our diagnosis. Nothing dangerous here, just things to think about and understand with atrial fibrillation. So the definition of it, or how you're going to recognize it on an EKG, is irregular rhythm, and you can actually feel this on somebody's pulse. You're going to feel it go beep, 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 and it's kind of all over the place when you're checking a pulse. Same thing on your monitor. But really, there's no clear P waves, and that's because the origin of the beat is not coming from the sinoatrial node. If you remember, it's a sinoatrial node conducting an impulse to the AV node that generates a P wave that's upright and in the right location, the right direction, the right distance from the AV node. Atrial fibrillation is where basically any little foci in the atria has taken over and is trying to send its own impulse to the AV node. It's very disorganized, very irregular, and they get through at irregular times because there's no systematic firing. And so that's why you see the irregular rhythm here with no discernible P waves, because they're not coming from the sinoatrial node. Very disorganized. You may see some fibrillatory waves, but don't call them P waves because they're not coming from the SA node. And then in general, you're going to see that you have a QRS that's narrow. So still some signals. That means that there's still signals getting through from the atrium through the AV node. So it'll give you a narrow QRS, but it's just not necessarily coming from the sinoatrial node because all those other foci are trying to take over. Big thing to know about AFib is it's a very big stroke risk, as that atria is fibrillating, blood isn't regularly moving through with a constant rate. There's time for blood clots to form, and those blood clots can go straight to the brain. And so that's why many of your atrial fibrillation patients, if they know they've had it for a while, they'll be on blood thinners to help prevent stroke. But sometimes if it's new, this is definitely something. If you have a patient who doesn't want to go to the hospital and they're trying to talk themselves out of it, let them know that this is a big stroke risk and they may need to be treated for that. Another important point here is that sometimes AFib can come and go. So some people live with it. It can be a consequence of valvular disease, ischemic heart disease, long-term high blood pressure. But not only that, those are kind of expected things that you can get with age or with progressive vascular disease. But there are other times where this can happen acutely, and a lot of times it has to do with electrolytes. So in the setting of acute infection, sometimes thyroid hormones being out of whack can cause this. Drugs and alcohol can actually cause it, so you may see AFib in some of your younger patients who are just intoxicated, and that's just because it's causing irritability in those atria and some of the electrolyte conduction there. So these are two things to think about. One could be underlying structural disease. The other is some sort of metabolic or electrolyte emergency that may be causing it as well. Really, our treatment in the pre-hospital setting, if it's a regular rate and they're otherwise stable, you can give them aspirin if they're having chest pain with it or they're symptomatic from it. Otherwise, we don't really treat it too aggressively until you develop AFib with RVR where the rates get really too high. So that is a look at a 12 lead that's atrial fibrillation, and a good one to know, good one to recognize. It's actually very common. So thank you for your attention today, and we'll see you next week.